This is a case of Mr. SIL, a 48-year-old male construction worker from Kanchanahali who belongs to the lower middle class according to Kuppuswamy classification. Patient presented with complaints of swelling in the groin since 1 year, pain over the swelling since 4 months. History of presenting illness. Patient was apparently normal a year ago when he noticed a swelling in the left groin which was insidious in onset and gradually progressed to the present size, and it stopped just above the root of the scrotum. The swelling is manually reducible. The swelling increases in size on standing up and coughing, and the patient also complains of a dull aching pain over the swelling since 4 months. This pain is aggravated on walking and coughing and relieved by rest. It is a non-radiating type of pain. There's no history of difficulty in micturition, constipation. There's no history of abdominal surgery or vomiting. There's no history of acute onset of severe pain. There's no history of a recent rapid increase in the swelling size. And there's no history of chronic cough. Past history. The patient is not a known case of diabetes, hypertension, tuberculosis, pulmonary tuberculosis, COPD, or ischemic heart disease. The patient is not presented with no history of swelling and previous history of swelling in the groin region, and there's also no history of previous surgeries. Personal history. The patient follows a mixed diet. He reported regular bowel and bladder movements, adequate sleep, and there's no addictive habits. Family history, there's nothing significant. Allergy histories are no known allergies. Summary. This is a case of a 48-year-old gentleman, construction worker by occupation, came with complaints of swelling in the groin region for the past year, which increases in size on coughing, straining, and disappears on manipulation. History of dull, aching, non-radiating type of pain over the swelling since 4 months, which is aggravated on straining and coughing and relieves with rest.
Yeah. From the history, what do you think the swelling is?
So, because from the history, since it is reducible and it is an inguinal scrotal swelling, we can think of hernia, sir.
Yeah, 2 cardinal signs of an uncomplicated hernia is?
So, 2 cardinal of uncomplicated hernia would be cough impulse and expansile cough impulse and reducibility, sir.
Yeah, that should be the answer. Okay. So, because they will ask you, why can't it be a lipoma? Why can't it be some other lymph node?
Okay, sir.
It's a groin swelling. So, go to the first slide.
Yes, sir.
So, what does your yeah, it's a male. What is the importance of the age, ma? We'll go from the basics first.
Okay, sir. So, yeah, in younger males, an indirect inguinal hernia is more common, whereas in elderly males, direct inguinal hernia is more common, sir.
Yeah, more common, that the word should be used, because not that in old age you will get you can get an indirect hernia, but it's more common because the weakness of the posterior abdominal wall.
Also, because there is more incidence of smoking in males, so that could lead to weak abdominal tension, so it's more prevalent.
Yeah, I couldn't get you, please. What you said?
So also because there's more report of smoking in male, so because of
I'll come to that. How does smoking affect your brain? It's a predisposing factor, you say.
So because smoking causes weakness of tone of the abdominal muscles.
No, any other reason?
I'm not sure, sir.
Teju?
Sir, smoking causes COPD and more cough and more intra-abdominal pressure rises.
Yeah, I am saying. Then collagen?
Sir, smoking, it will affect that collagen synthesis.
So there will be more.
It causes breakdown of more collagens.
Okay. So go to the next slide. Yeah, you said groin.
Yes.
Do they accept that word now? When you have to say in the history, you have to say the patient's own words. So if somebody, have you been taught like that? Then no problem.
So in our report, like in the file in the hospital, was it in groin?
The file they'll be right, but your teachers may ask you to say it is swelling in the right lower abdomen. That should be better.
Okay, sir.
But now you can interpret what the patient says and put it in your word. Okay.
Yes, sir.
You said groin. Is there a difference between the inguinal region and the groin?
Okay, sir.
No, is there a difference between the inguinal region and groin?
So it can be differentiated from by the inguinal ligament, sir.
No, when you flex the thigh, the inguinal region and the upper one-third becomes the area is called the groin. Okay. You flex the thigh. You flex the hip.
Yes, sir.
The inguinal area, inguinal region and the upper one-third of the thigh, that together is called the groin. Okay.
Yes, sir.
You understand me?
Yes, sir.
Right. Pain over this swelling. Okay. Go to the next one. Usually, why you will get a pain in the case of a hernia?
Excuse, so can you please repeat the question?
Can you usually get a pain in a case of hernia?
Yes, sir. Pain
Normal,
is pain
nor,
is a
normal uncomplicated hernia. Do you get pain?
in sir, from
I will tell you. It is nothing but initially you may not have pain, but the swelling when it becomes enlarged, what happens is due to the dragging of the momentum, you
yes,
get the pain. Okay. So you will have a dull aching pain unless when it becomes complicated, it goes in for the severe type of colicky abdominal pain because of the
strangulation.
no, you don't say that's what I usually tell the students. Don't straight away go in for strangulation. But that's a sequence which goes on. See, a reducible swelling first becomes an irreducible swelling. Okay, that is the
Yes,
first
sir.
step of complication. The second step which goes in is obstruction. Then only it goes in for strangulation. Okay, this is the
Yes.
step it goes on. Okay.
So I have a doubt then. In
Yeah.
our textbook, it had mentioned that pain is common symptom that's seen even before the protrusion of the viscus happens, and then it's present all throughout the progression of the hernia and stops only after the hernia.
When it starts coming, that's called an occult hernia. When there is no hernia seen, you get something pain like thing, but you will not able to be appreciating that one. Okay.
Yes.
No, when the hernia comes down, what happens is a descent of the, what is the actual meaning of hernia?
Sir, it is a protrusion of the viscus or a part of it through the wall.
Yeah, that is. So when it comes down, it pulls the drags the momentum, so you'll have a dull aching pain. Okay.
Okay.
Okay. Go to your next slide. Yeah, swelling is manually reducible. Reduced by the patient itself, or you reduce it?
So the patient could reduce it on his own.
Gradually progressed, it stops about the root of the scrotum. Has it got any significance in it?
Sir, it can, if it comes to the bottom of the scrotum, then it's a complete hernia. But if it stops at if it does not enter the scrotum, come to the bottom, it's an incomplete hernia.
Right. Increased size and standing up and coughing. Aggravated on it. No, good. Go to your next slide. Yeah, why are you asking all this?
So no history of difficulty in micturition, sir. Since it's a male patient and also he's significantly like an older patient. So if in case there is a benign prostatic hyperplasia that's missed, then during strain during micturition, that time that could be one of the causes of the hernia. Or if there is any burning micturition or dribbling of the micturition.
What are the things you will ask in the micturition?
So if there is any difficulty during micturition,
the earliest symptom of a prostatic hypertrophy is nocturia. Okay. Patient will have severe urine in the night. Okay, frequency of urine, urgency, frequency, dribbling, thin stream of urine. This is how it process. Then difficulty. On later stages, it may go in for hematuria. So start with nocturia, urgency, frequency, all these things. So in 48 years old, 48 year is not a old age actually now. But all these things you are asking, and this per se will not produce hernia. Okay. Why you are asking for micturition difficulties? If the patient has got any micturition difficulties, it has to be corrected prior to surgery.
Yes, sir.
That is the reason. So constipation, patient has got constipation. Okay,
So,
abdominal.
constipation, abdominal distension, vomiting, it could
That is in the case of
obstruct.
obstructive hernia. But this patient doesn't have anything, isn't it?
Yes, sir.
No, any other cause of constipation. Patient will have habitual constipation. Patient may be on any drugs, psychotic drugs, narcotic drugs will have constipation. So this training again will be there. So after
Yes, sir.
surgery, this should be corrected. If it is constipation is there, it should be corrected and done surgery. Okay.
Yes, sir.
So you should know history of vomiting, acute onset of severe pain. Why you ask for abdominal surgery?
So previous abdominal surgery, for example, if there was an previous appendicectomy, there could have been a nerve dissection which could have caused the weakness of tone of muscle.
So what hernia you get usually when you have a disruption of the nerve in abdominal surgery?
An incisional hernia, sir?
You get an incision hernia because the which nerve you damage in the appendicectomy?
I'm not sure, sir.
Did you?
Sir, this iliohypogastric nerve, sir.
Inguinal nerve or hypogastric. You stop scared.
Sir, ilioinguinal nerve supplies abdominal muscles before entering the inguinal canal, sir. If it is cut outside the canal, then it will weaken the muscle and cause direct hernia, sir.
Yeah, that's correct. It will not cause the direct hernia, usually cause incision hernia because it supplies the cutaneous innervation of the skin.
Okay, sir.
Direct hernia comes from the posterior aspect. What
Okay,
happened to Nandini?
So just 1 second, sir.
No problem. Only one person has joined. Shivani J. Where are you from, Shivani? Please switched on a minute.
Sir,
Which college are you from, Betty?
sir, Coimbatore Medical College.
C2A.
Next slide, sir.
Yeah. So this chronic cough, all these are predisposing factors. One thing is these are the factors which has to be corrected prior to surgery. Otherwise, you will get recurrence. That is the importance of asking all this. The chronic, how many patients of chronic obstructive pulmonary disease or tuberculosis are, that means all the TB patients, all the COPD patients should present with hernia. They don't present, is it not?
Yes, sir.
So why you are asking is, these are the factors which has to be corrected prior to surgery. That is why I'm asking for history of constipation, micturition, and chronic cough. Okay. Are you getting me, Nandini?
Yes, sir.
Right. Mixed diet, regular blood, adequate sleep, no addictive habits. Yes. Family history, there's nothing significant. You will not get a hernia running in families.
Yes, sir.
Unless you have the connective tissue disorder where you will have, but that is very, very, very rare. Allergic history, yes. Next.
Summary, a 48-year-old gentleman, construction worker by occupation.
Yeah, you are told.
Yes, sir.
So you are told what is the probable diagnosis. This could be a hernia.
Yes, sir.
Because of two important conditions. Now, next. How do you examine the patient?
So the general physical examination, informed consent was taken and the patient was examined in a well-lit room with adequate exposure. Patient is moderately built and nourished. Patient was conscious and well-oriented to time, place, and person. Vitals, temperature was afebrile. BP of the patient was 131/75 millimeters of mercury. Pulse rate 80 beats per minute. SpO2 96% in the right arm. No pallor, ictus, cyanosis, clubbing, lymphadenopathy, and edema or skeletal deformities are noted.
Good.
Local examination. Patient was exposed from the nipples to the mid-thigh. Patient was examined in both standing and sitting position. Inspection. A 3 into 3 centimeter globular swelling was
Nipple is not necessary, ma. If it is the groin,
okay, sir.
then expose from the umbilicus to the mid-thigh.
Okay, sir.
That is enough. But of course, if you are examining other system later on, but for this case, in inguinal hernia, you examine from the umbilicus to the mid-thigh. Okay.
Yes, sir. Skin over the swelling is normal. There are no scars.
Why sitting position, ma'am? Is it standing or lying position? Why sitting position?
Standing and lying position. Sir.
Yeah, correct. That. Sitting position, do you have exam in hernia?
No, sir.
Inguinal hernia, I must. No, yes.
No, sir. Inspection. 3 into 3 centimeter globular swelling was present over the left inguinal region. The skin over the swelling is normal. There were no scars or dilatation or sinuses seen. Swelling expands on coughing. There is no visible peristalsis observed. Right inguinal region appears to be normal. The penis is not pushed to the opposite side. Other hernial orifices are intact. Palpation. There is no local rise in temperature. A swelling of 3 into 3 centimeters present over the left inguinal region above and medial to the pubic tubercle and extending up to the root of scrotum. There is no tenderness palpated. The dewy consistency of the swelling is noted. Not possible to get above the swelling. The testis is felt separately from the swelling. Expansile cough impulse is present. Swelling is reduced manually. There are no gurgling sounds noticed. Deep ring occlusion test is positive for the indirect inguinal hernia. There's right inguinoscrotal region is normal.
Yeah.
Abdominal tone examination. No undue protrusion of lower abdomen on standing. No malgagneous bulge is seen. Normal tone of the abdomen muscles is noted. External genitalia. Skin over the scrotal skin is normal. Testis is normal. Normal bilateral spermatic cord. The normal penis. The urethral opening is normal. No enlargement of the inguinal lymph nodes. Systemic examination. Respiratory system normal. Bilateral normal vesicular bed sounds is noted. CVS S1 and S2 is heard. No murmurs are noted. CNS no focal neurological defects. Per abdomen, there are no scars, organomegaly, palpable mass, tenderness, ascites, bowel sounds are present. All quadrants move equally with respiration. Examination summary. On examination, a globular-shaped, non-tender, reducible right-sided left-sided inguinoscrotal swelling lies above and medial to the pubic tubercle, extending up to the root of the scrotum with expansile cough impulse and ring occlusion test positive for indirect inguinal hernia. So I'm sorry about the mistake. It's reducible left-sided.
No problem. No problem.
Left-sided incomplete reducible indirect inguinal hernia containing omentocele.
Yes. Yeah, now go to your clinical examination. We'll come back. Yeah, you have done everything very good. You mentioned SpO2.
Yes, sir.
Now, some examiners are very particular. Is the patient COVID positive or not, recently recovered? Because you are examining the patient, isn't it?
Yes, sir.
Right. No pallor, icterus, sinus clubbing. All these things are very important because the patient has got pallor, it has to be corrected.
Yes,
Why?
sir.
Anemia decreases the time of wound healing.
Yes, sir.
Icterus, yes, used for anesthetic purposes. Any liver dysfunction, again, the anesthetic purpose, icterus has to be found out and corrected.
Yes,
That
sir.
may be not associated with hernia, but it may be associated with any medical condition which we are missing.
Yes, sir.
In general, cyanosis, the sinus clubbing, lymphadenopathy, all these things are to be. Yes, skeletal deformity is one thing which you have added, is very good because you have to look for the spine for anesthetic purposes.
Yes, sir.
Right, good. Go to the next. You have inspected. Now, I usually say globular swelling, never say globular swelling because globule means you have to see the whole circumference.
Okay, sir.
So you can say either hemispherical or pyriform.
Okay, sir.
If it is a direct, it is, they say classical shape, they give us a hemispherical. If it comes along you said it's indirect. Indirect comes through which region?
So indirect comes through the Hasselbalch triangle and then out of the superficial environment. I mean, sorry, sir. Indirect comes from the deep inguinal ring through the inguinal canal and the superficial.
Nandini, you relax. This is not an exam. It's only a teaching schedule.
Yes, sir.
Okay. So you don't get tense. Right. You can get so indirect comes through the
Deep inguinal ring through the inguinal canal and out the superficial.
Yeah. Superficial. The direct comes through the
Hasselbalch's triangle and then out to the
Hasselbalch's triangle. You say that is enough. Okay.
yes, sir.
Now, they usually what the question they ask is, I'm just examining wise. I'll finish now and then. Okay. So the examiners will ask you, what are the normal factors which prevent hernia formation when the normal people? We are God given something. Okay. Tell me. Shivani, do you know? Somebody
So
else?
tone of the abdominal muscle, sir.
Yes. More than that. With the canal itself, we have something. Shivani, can you answer? He's from Coimbatore Medical College. I think she has left.
Sir, excuse me, sir. Good evening, sir.
What are the factors which prevent hernia formation in a normally we have got some mechanisms in the body, isn't it?
Yes, sir.
What are they?
Obliquity of the inguinal canal.
Yes, one number. You can note it down, Nandini. Obliquity of the canal. The canal is oblique. So any increased abdominal pressure will not come directly. It takes a roundabout route which gets weakened. Okay. So obliquity of the canal is one. Number two.
Shutter mechanism of the internal oblique muscle.
Shutter mechanism. That is when the patient coughs or strains, Nandini.
Yes, sir.
1 minute. I'm in a class. I will call you after 8 o'clock.
Sure, no problem. Thank you.
So that is when the patient coughs, both the anterior and posterior walls close like a shutter.
Yes, sir.
Okay, Nandini, number 3. Yes, Shivani, tell me what is.
Ball valve mechanism, sir.
Yeah, again, when the patient coughs or strains, what happens is the part of the cremasteric muscle acts like a ball, comes and plugs the superficial ring. You understand, Nandini?
Yes, yes, sir.
Number 4 is
Slit valve mechanism, sir.
slit valve mechanism or a pinch cork mechanism. The superficial ring is an inverted V shaped. So what happens is when the patient coughs like a pinch cork, it closes.
Yes, sir.
So these are the 4 factors. Now can you repeat it, Nandini?
So the obliquity of the inguinal canal, sir.
Yes.
And then the shutter muscle, the shutter
Mechanism.
mechanism is action of the oblique muscle, sir.
Yeah.
And the ball valve mechanism where the cremasteric muscle blocks the inguinal superficial inguinal ring, and the slit valve mechanism, sir.
Yeah, these are the things. Okay. So now you know these are the mechanisms. Now they can next question they will ask you where is the deep ring situated?
So the deep ring is situated about 1.25 centimeters superiorly to the mid-inguinal point, sir.
Right. What is the mid-inguinal point?
So the mid-inguinal point is the midway between the anterior superior iliac spine and the pubic symphysis, sir.
Symphysis. What is the point between pubic tubercle and anterior superior spine?
So that is the midpoint of the inguinal ligament, sir.
Yeah, right. So the deep ring is situated 1.5 cm, 1.25 cm. Where is the deep ring actually in the body? Which muscle?
So the deep ring is lateral to the rectus abdominis.
No. There are 3 muscles, isn't it? External oblique, internal oblique, transverse abdominis. Now the defect, the super deep ring is situated in which muscle? The defect in which muscle? Yes, Teju is waiting.
Transversalis, sir.
Transverse abdominis muscle. Okay. External ring.
External oblique is for superficial inguinal ring, sir.
Yes, Nandini, deep
Yes,
ring is a defect in the transverse abdominis. You understand? See, external oblique, internal oblique, transverse abdominis. Okay. So the deep ring is situated deep in the transverse abdominis. It is a U-shaped ring.
Yes, sir.
This one is a inverted V shape like this.
Yes, sir.
It's situated in the external oblique muscle. So these are the questions. Now, direct hernia comes out through the Hasselbalch's triangle.
Yes, sir.
What are the boundaries of the Hasselbalch triangle?
So the Hasselbalch triangle is bounded inferiorly by the inguinal ligament, sir, medially by the outer border of the rectus, and superiorly by the inferior epigastric vessels, sir.
Yeah, that's good. Yes. So here the skin of the swelling is usually, unless it gets infected or inflamed hernias or in its in strangulate hernia, the skin will be normal.
Yes, sir.
Swelling expands on coughing. That is called expansile cough impulse. No visible pits, right inguinal region. Go to your palpation. No local rise in temperature. Yes. You can say inspective findings are confirmed. Okay.
Okay, sir.
Yeah. You said Duffy inconsistency. What does it mean?
So, doughy inconsistency would be a way to differentiate between an omentocele and enterocele. In omentocele, we'll find a granular doughy consistency, whereas in enterocele, it will be more elastic and soft.
Very good. Very good. Not possible because usually which swellings are able to be get about the swelling?
So, the scrotal swellings like
Yeah,
the
very
hypercene will go above.
Yeah, remember this point. When they ask why do you say it's hydrocele, the first point you say is I'm able to get about the swelling.
Yes, sir. And
So,
reducibility.
No, I'm telling you, not here. When it okay, we are given a case of hydrocele. Why do you say it's hydrocele? It's a scrotal swelling. I'm able
Yes,
to
sir.
get above the swelling.
Yes, sir.
This is an inguinal scrotal swelling, so you will not get above the swelling. Why do you want to say testis is palpable separately from the swelling?
So we want to know whether the swelling is coming, it's a part of the testis, that is, it's a testicular swelling or.
Okay, that is one thing. In congenital hernia, sometimes you will not be able to palpate the testis in adults.
Okay, sir.
Because the sac will be there, up to the sac will be there, the testis will be inside. Okay.
Yes, sir.
Expansile cough impulse, okay, swelling is reduced manually, no gurgling. So when you reduce it, what are the points you look for? One,
whether or not there are gurgling sounds.
yeah, one is you say it reduced with the gurgle or not. Yes, one. Number two is
Which part of the swelling reduces
reduced
easily
first.
or not?
yes. Number three, as you said, when you reduce it, you can look for the consistency one. Now, when it reduces, which part is difficult to enter? The first part is difficult to enter. It is called.
So if the first part is difficult to enter, then it is a enterocele, sir.
Yeah, you should say. Yeah, that is what enterocele enters with difficulty. You can remember.
And omentocele, the second part is difficult to reduce, sir.
Omentocele, the last part is difficult to enter.
Reduce.
So reduce with the gurgle. All these things you could have to notice.
Yes, sir.
Now they will usually ask you what are the classical tests you do to
Yes,
differentiate between a direct and indirect.
Sir, the most important test would be the deep ring occlusion test, sir.
Right. Will you do what? The test, will you do it in the standing position or the sitting, lying
So
down?
initially, you have to make the patient lie supine and occlude the deep.
Okay, you've done it. You've done it.
Yes,
You
sir.
saw the swelling coming out or not?
Sir, only after removing the finger, the swelling is coming out.
No, when you do the test, is it coming out or not?
I'm not sure of the question, sir.
No, you occlude the deep ring. Is the swelling appearing medially or not?
The swelling up when after without removing the finger, the swelling did not appear, sir. Only after.
So you are occluding the deep ring.
Yes, sir.
So the swelling doesn't come out. So it's an indirect inguinal.
Yes, sir.
If it comes out,
then it is suggestive of a direct indirect inguinal.
direct. Yeah. Okay. No, that is why we say you use the thumb for occluding the deep ring.
Yes, sir.
Because the deep ring is situated deep, and depending on the obesity of the patient, you can occlude it with the thumb is the best one.
Yes, sir.
In spite of occluding, there are some faulty things in an internal ring. That is called the fallacies of the internal ring occlusion test. Can you tell me what are they?
I'm not sure. Of
Right. That means you are not occluded properly, Betty. So you may just keep your finger just like this.
Okay, sir.
Okay. What happens? Patient coughs. your finger also comes out. So you have to occlude it properly. One. Sometimes the ring will be wider than your thumb, based on the size of your thumb. You understand me?
Yes, sir.
The internal ring will be wider than your
Thumb,
thumb,
sir.
so it can come out. The
Yes, sir.
third possibility is it can be a
Pantaloon hernia, sir.
yes,
Both
it can
direct
be
and indirect.
both direct. And it's called a pantaloon
Pantaloon.
hernia or a saddle hernia. Okay,
Yes, sir.
all these things are there. Now, with this, I'll ask you one more question, which you usually ask sometimes in the exam. How do you identify whether the sac is direct or indirect on the operating table?
On the operating table.
Wait, Teju, wait, later we will give her. Teju is waiting to answer because she listened to the case in the National Forum. Yes. Nandini, I'll tell you. You do not know?
No, I'm not sure, sir. I was thinking
Because,
about.
yeah, once you see, you go to the operation theatre, your surgeon shows you, sir, this see Nandini, this is direct, this is indirect. You
Yes, sir.
cannot do a cough impulse test there.
Yes, sir.
So how do you identify? Yes, now Teju you can answer.
Ring imagination.
Sir, based on sac, sir, sac will be anterolateral in case of indirect and posteromedial in case of direct hernia, sir.
Yes, this is one point, Nandini, you note of anterolateral to the cord structures and posteromedial. In another, the simplest answer is based on the inferior epigastric artery.
Okay, sir.
Based on the inferior, if the sac is medial, it is direct. If the sac is lateral, it is indirect.
Okay.
Because the boundary, the lateral boundary is formed of the SL bax is formed by the inferior epigastric artery. Okay.
Yes, sir.
So the sac should be medial that is the thing you should know. So
Yes,
your exam, what are the other tests you
sir,
know?
could you please repeat that, sir?
The triangle is like this, isn't it?
Yes, sir.
This is the medial, this is the medial border, this is the lateral border. Okay.
Yes, sir.
If the inferior epigastric artery, this is the inferior epigastric artery. If the sac is medial to the inferior epigastric artery, this is direct artery. You understand?
Yes, I'm noting it down, everything that you say, sir.
If the sac is lateral to the inferior epigastric artery, it is indirect. Based on the sac.
Yes, sir.
Because usually this neck of the indirect hernia sac is lateral to the inferior epigastric artery.
Yes, sir.
Okay. So that is a question which is asked. So you did a deep ring. What are the other tests you are being taught to do?
So the other tests would be the Zeeman 3-finger test.
Yeah,
and
where do you
also
keep the three fingers?
Sir, the 3 fingers used are the index, middle, and the ring finger. So they be kept on the deep inguinal ring, superficial inguinal ring, and the femoral ring.
Yeah, based on your deep ring occlusion test, you can modify your Zeeman's technique inference. Okay.
Yes, sir.
Now, the ring finger invagination test is not done nowadays.
Yes, sir.
It was done previously. Now they are not doing it. But if your teacher teaches you,
yes, sir,
please do tell. Okay.
Yes, sir.
I think Teju told that one, and somebody asked, do they still teach? Is it not, Teju?
Yes, sir. They will still tell in our college.
Yeah.
And it is the only test which is done in supine position. Other tests will do in standing position. After reducing the content, will do in standing. But this is the only test in supine, sir.
And they were asking you, are you still being taught, isn't it?
Yes, sir. Yes, sir.
Yes. So, Nandini,
Yes, sir.
So all tests are done in the standing position except the finger invagination test. If they teach you, you have to say. Otherwise, you need not say because it's a cumbersome procedure.
Yes,
not done. Now go to the other one. Right side is normal. Yes. Go to the next slide. Call me later. You call me later, I said. Don't you hear me? Yeah, tell me.
The abdominal tone examination, sir.
Yeah, you look for the malgagnis pulse usually. That is weakness of the
Yes. The lower abdominal wall, sir.
So you ask the patient to raise head rising test. Yes, next.
Yes, sir. The shoulder is raised in the recumbent position. You raise the shoulder against the resistance and look at the lower abdomen. If you see oval, longitudinal, bilateral swelling, then.
Right, very good. Good. Next slide. So examine the external genitalia. If everything is normal, you can say
Normal.
external genitalia is normal. You need not put everything
Okay,
like
sir.
this. So as you said, you have to look at this scrotum. Now come to that slide.
Sorry, sir.
Scrotum you see.
Yes,
Scrotum, what are the things you see is one is the scrotum well developed, hemiscrotum or scrotum well developed. Okay.
yes, sir.
Is that both the testes palpable? Bilateral spermatic cord, yes. Now, what are the things you look in the penis? I used to teach, remember, 3 P's. One is
The position.
pinhole meatus.
Okay.
Okay.
Yes, sir.
Phimosis
Phimosis.
and penile urethra.
Okay, sir.
Right. You said normal urethra. You palpate on the undersurface of the penis,
Yes,
and
sir.
you have to lift the scrotum to look for the bulbar urethra.
Yes, sir.
Let me ask you. No enlargement of the inguinal lymph nodes. Yes.
Next slide, sir.
Yes. Right. You have one thing you have to write to mention is rectal examination not done, sir.
Yes, sir. Actually, since our UG, they didn't let us do it, so I hadn't mentioned it in the.
No, you have to mention it at least.
Yes, sir. Okay, sir.
Because PR not done, sir.
Yes, sir.
They don't allow you to do, but you should mention why PR is done.
So, rectal examination is done to rule out, if in case the patient presents with constipation, to rule out other causes of constipation like a fissure or hemorrhoid, sir. And also, if there is a benign prostatic hyperplasia, it can be.
Okay, now come to your other systems. You can say clinically normal. Okay.
Yes, sir.
All good. What so your diagnosis is? What is your diagnosis? Let's say that complete inguinal hernia.
Yes, sir.
Come to your diagnosis. Complete indirect inguinal hernia. Why do you say it's incomplete? Why do you say it's?
So a complete hernia would be one reaching the bottom of the scrotal sac or the labia majora.
So it's incomplete.
Incomplete, sir.
So incomplete, do you have any types? 2 types are there. When it stops at the root.
Root
Yes.
of the scrotum, and if it extends below into the scrotum, sir.
Yeah, that is incomplete and complete. Incomplete, you have 2 types.
Pubenosyl and funicular, sir.
Yes, when you just feel an impulse at the deep ring,
Yes, sir.
it is called bubenosyl. Just a cough impulse alone.
Yes, sir.
When it comes up to the root of the scrotum, it's called the funicular hernia.
Funicular bubenosyl. Okay, sir.
Okay. Now how are you going to manage this patient?
So since it's not a congenital hernia or it's not infected or strangulated, the best the surgery of choice would be a Liechtenstein tension-free mesh hernioplasty or a laparoscopic repair, sir.
Right, Nandini, you have to investigate. So when I say how will you treat means you can say I will do a surgery. When I say manage the patient means you should say I will investigate and treat the patient. Okay.
Yes,
so
sir.
Investigation, let me ask you. Investigations, when you do investigation, is hernia a clinical diagnosis or is it you have to diagnose through some investigation?
So if the hernia is not palpable, then we can do ultrasound.
Here it is a clinical. Always hernia is a clinical diagnosis. The only indication where you want to do an MRI or a CT is for occult hernia.
Yes.
The patient says there is something coming, protruding out, I feel some pain, or as you said, there is an initial evolvement of the hernia.
Yes, sir.
Occult hernia, you can do an MRI. Otherwise, you need not do anything to confirm.
Yes,
so hernia is a clinical diagnosis. Now, why do you do other diagnosis is to prepare the patient for surgery and anesthetic purposes.
Yes.
So you do your routine investigations, your anesthetic investigations, your routine blood, complete blood count,
Hemoglobin,
protein, hemoglobin, blood urea sugar, serum creatinine.
HbS,
Yeah. Now you can even do COVID positive, COVID test. All these things are there. If you want, you can do an ultrasonogram if the patient is aged person and has got some problem with micturition. You can look for the ultrasound to look for the prostatic enlargement.
Yes, sir.
So how do you know the prostate is enlarged? You measure some urine. What is residual urine?
So since in prostatic benign prostatic hyperplasia, there won't be complete voiding of the urine.
So that is why we call you do the post voiding. You take it with the full bladder. Any abdominal scan is done with a full bladder. Ask the patient to void post voiding. You do an ultrasonogram. Measure the residual urine. What is the normal residual urine?
I'm not sure, sir.
Teju?
Sir, I am also not sure.
So up to 50 to 80, 150, some people 30 to 50 ml is normal. It goes up to, when it goes crosses 100 ml, it is significant. Measurement of the residual urine. Okay. So now your patient is completely assessed and everything. Okay, Nandini?
Yes, sir.
Now, why do you want to do surgery? This patient has got just a swelling with mild pain.
Yes, sir.
Patient is asking, give me tablets. Because nobody would like to undergo surgery.
Yes, sir.
You know, surgery is the mainstay of treatment.
Yes, sir.
But nobody, as soon as you go, even for a small lipoma, they'll ask, give some drugs and make it shrink.
Yes, sir.
So, can you make it shrink? They will ask you. So, you have to tell the patient, you have to cite out the reasons for doing surgery.
Yes, sir.
Tell me, why?
Sir, the hernia could progress to a complicated hernia or a strangulated hernia.
Yeah, it can go in for complications like irreducibility, obstruction, and strangulation.
Yes, sir.
What is the difference between obstruction and strangulation?
Sir, an obstructed hernia, also known as an incarcerated hernia, sir, it is irreducible and there is no cough impulse, but the blood supply is intact and obstructed.
Yeah,
whereas in a strangulated hernia, there is a compromised blood supply, sir.
Yeah, blood supply is intact. In obstruction, only the lumen is obstructed.
Yes, sir.
In strangulation, even the blood supply is obstructed.
Yes, sir.
So you are console the patient, you are taking up the patient. What is the surgery you want to do?
Sir, it depends on the affordability of the patient, sir.
Why affordability?
We can either go for a laparoscopic or a
No,
mesh.
you first tell what is the basic.
Sir,
Don't bother about the affordability or anything. Now everybody is affordable. Now everybody has got the schemes to do it.
Yes, sir.
When as an undergraduate, if we ask means I will do surgery, sir. I will do surgery to prevent the complication.
Yes, sir.
So what surgery you will do? So you have three types of surgery.
Yes, sir. The three types are herniotomy, herniorrhaphy, and hernioplasty, sir.
Right. Where do you do herniatomy?
So the indications for herniatomy would be a congenital inguinal hernia or a congenital hydrocele, sir.
Don't say it. Okay, that's fine. Okay. You can say congenital inguinal hernia in children. Okay.
Yes, sir.
So some adults will come with congenital hernia, which they rather forgot or neglected the swelling.
Yes, sir.
Congenital inguinal hernia, you just do a surgery.
Yes,
That
sir.
is, just you do ligation of the process vaginalis sac, or you cut the sac and leave it.
Yes,
Okay.
sir.
Now, herniorrhaphy and hernioplasty are the two mainstay goals of treatment previously.
Yes, sir.
Now it has come to hernioplasty.
Yes, sir.
So hernioplasty and hernia. So we'll go with first. You tell whether do you know about herniorrhaphy?
Yes, sir. Herniorrhaphy, basically, sir, there are 3 steps. The step 1 would be to identify the sac and push the contents inside. The step 2 is in case if the surgeon has opened the sac, that we have to close that defect. And step 3 would be to suture the 2 edges of the defect, sir.
Now I will tell you. You are correct. One is herniatomy. That is identify the sac.
Yes, sir.
But in direct sac, you don't open it.
Okay, sir.
In indirect, you have to open it. Because you have to see the contents and push it into the abdominal cavity
Yes, sir.
because the neck is narrow in an indirect sac.
Yes, sir. Yes, sir.
Whereas the sac has got a wide base, the neck is wider in a direct sac, so you don't open the sac in a direct hernia.
Yes, sir.
That is the reason. Okay. So you have opened the sac, push the contents inside. So the important step is strengthening. This is noted down. Strengthening of the posterior wall of a canal, inguinal canal, is the mainstay treatment in an inguinal hernia.
Strengthening of posterior wall.
Posterior wall of the inguinal canal. Because the hernia goes down, comes out through the weakness of the posterior wall, it comes and projects anterior.
Yes, sir.
So to prevent recurrence, the posterior wall should be strengthened. The
sir.
strengthening can be done in two ways. One is using the natural tissues. That is called herniorrhaphy.
Yes, sir.
There are 2 or 3 techniques. One technique is Bassini,
Yes, sir.
modified Bassini's technique,
Shoulders
and shoulders repair. Shoulders, how many layers do you know?
Shoulders can be done in either 3 or 6 layers, sir. The first layer would be double breasting of the fascia transversalis, sir. And the second layer would be double breasting of the conjoint tendon and suturing it with the reflected inguinal ligament, sir. And then the third layer would be double breasting of the external oblique aponeurosis,
So
sir.
it's a 6 layer shoulders.
Six layer,
Another one is the modified Bassini's repair.
yes, sir. In
Where-
Bassini's repair, we do just suturing of the conjoint tendon with the reflected portion of inguinal ligament, sir.
Yeah, another word which you add is using non-absorbable suture material.
Okay, sir. Okay.
This was the mainstay of treatment during my studies, and it was holding good also. When newer things come, they change into newer one. Is it not?
Yes, sir.
You had an ordinary phone, now you come to Android. Now what else?
Yes.
So you buy latest model like that.
Yes, yes.
The newer treatment has come now from the hernioplasty. It has gone. No, herniorrhaphy is nothing but strengthening of the posterior wall using the natural tissues.
Yes, sir.
Now, hernioplasty is strengthening of the posterior wall using artificial material.
Yes, sir.
What do you place posteriorly?
The mesh, sir.
Right. What is that surgery named called?
Sir, it's the Lichtenstein's tension-free mesh hernioplasty, sir.
Right. Lichtenstein's tension-free mesh hernioplasty. Where do you suture?
Where do we suture?
Where do you place the mesh? So inferiorly, you take a bite from the which part? Teju?
Sir, periosteum of the pubic tubercle.
Yeah, you can take from the periosteum and do a continuous suture of the inguinal ligament. Okay.
Yes, sir.
And when you come laterally, you have to do a fishtailing. That is to keep the cord structures above it.
Yes.
See, the cord structures are running. You have to strengthen the posterior wall.
Yes, sir.
Oh, you do a fishtailing, that is fish mouth. Keep the cord structures in between and place it anterior to the mesh. Okay.
Yes, yes, sir.
Unless you see a case, you will not understand better. You can see a case or see a YouTube video. Okay.
Yes, sir.
Right. Then upper superiorly it can be placed. You can suture with the conjoint tendon. This is Lichtenstein tension-free hernioplasty. Right. These are the 2 methods. Do you know any other method of doing? As you said, affordability. Patient doesn't want scar.
So then we can go for laparoscopic method, sir.
Yeah. What are the laparoscopic methods? You know.
So there are 2 methods, sir. TEP and TAP. TEP will be totally extraperitoneal, and TAP is trans-abdominal peritoneal repair, sir.
But where do you keep the mesh in both?
So in extraperitoneal, it will be above the
In both, it is kept in the preperitoneal space.
pre-peritoneal.
Only the route of approach is different. Okay, that is why it's called total transabdominal. Go through the abdominal, dissect, but you keep the mesh in the
Pre-peritoneal.
preperitoneal.
Okay.
It is totally extraperitoneal mesh. Suture it with a non-absorbed. Do you know any laparoscopic anatomy?
I'm not sure, sir.
Suppose you have
But the triangle of doom and the triangle of pain. Do you mean that, sir?
Yeah.
Uh,
What is
in-
triangle? Yeah,
Can
you're
you please
answering.
repeat the question?
You are answering well. Only thing you are not getting my questions. Or
My
my
audio is not that good. I'm very sorry, sir.
I think my English is poor.
No, not like that, sir. I use the hostel Wi-Fi, sir. The
No
audio is not
problem.
that.
I'll tell you. So you should know. I'll ask you to read these things because they will ask you. Triangle of doom.
So the triangle of doom is a space wherein superiorly you have the deep inguinal ring, medially we have the vas deferens, and then laterally is the testicular artery, and inferiorly it is bound by the peritoneal reflection. So it contains three. The contents are the external iliac artery, the vein, external iliac vein, and also the genital branch of the genitofemoral nerve.
Fine, very good, very good.
So if a stapler is put in this area, that it could lead to hemorrhage.
Okay. What is triangle of pain?
So the triangle of pain is right adjacent or lateral to the triangle of doom. Superiorly, it's bound by the canal.
It's the same thing. Instead of testicular vessels, you have the iliopubic tract.
Yeah, yes, iliopubic tract.
Sorry, instead of vas deferens, you have the iliopubic tract. You have the peritoneal fold and the testicle. Why it's called the triangle of pain?
So it is because it contains the lateral cutaneous nerve of the femoral nerve, and also the femoral branch of genitofemoral. So if a stapler is put here, one of these nerves can get entrapped, sir, most commonly the lateral cutaneous nerve of and it can cause pain, sir.
Right. What are the other things you know? What is myopectal orifice of Rorschach?
Myopectal, sir, in myopectal is this is a place where the inguinal, femoral, and the obturator hernias it can open into this orifice, sir. So a mesh should always be put in to cover this area during laparoscopy.
So you put a mesh in that one, it covers all the three things.
Yes, sir.
Suppose you have a patient with bilateral direct hernia. Is there any other open method you know?
So for bilateral direct, if it's an open method, so I learned that the most recent hernia should be operated first.
There is one method where you don't put an inguinal incision, you can put a midline incision.
Okay, sir.
And just stage you, do you know that? Or in Shivani?
Not sure, sir.
It's called the Stopas.
Stopas
or GPRVS. Giant prosthetic replacement of the visceral surface. GPRVS.
Okay, sir.
So that is one thing which was done. Even some people do now, where there's bilateral direct hernia, you open the midline, create a space, and suture it. Put a big mesh and suture it. It's called the Stopas technique.
Okay, sir.
So you are told about hernia, you have done well. So the certain points which you have enlightened, hernia can be taken. Hernia is one of the commonest case kept in the exam, commonly discussed case, commonly seen case in the theatre, commonly seen case in the OPD, but one of the difficult cases in the exam because the questions will be more. What I've asked is only 20%. I have not gone to the depth. Okay. What is needed for an undergraduate, I told you.
Yes, sir.
So this way. Now you have some classification, you have to read about the classification.
Yes, sir. There are three classifications, sir.
Yeah, name it.
Gilbert, the NIHS, and the European Hernia Society.
Yeah, EHS is followed now.
Yes, sir.
Because Bailey gives EHS. So can you enlighten on EHS?
Yes, sir. So there are three the factors that contribute to classification. P is for primary hernia, or you can use R for recurrent hernia. L is lateral or indirect hernia, and F is medial or direct hernia. And F indicates femoral hernia. And the defect size is measured in finger breadths. So 1 finger breadth is considered as 1.5 centimeters of defect, sir.
2, 3 is there. 2 finger breadth, 3 finger breadths.
Yes, sir. Yes, sir.
So now the EHS is there. NIHS, they may ask you.
Yes, I'm not sure about that, sir.
Yeah, NIHS you can read. Just read and keep it.
Yes, sir.
Gilbert has might been modified by Rutkoff. That's another thing. There's a lot of classification, but you remember two things.
Yes,
You
sir.
can tell the examiner, I know only EHS and IS.
Okay, sir.
That is enough, which is easy for you to read. You can read and keep it up.
Yes,
So
sir.
some hernias based on the contents, can you say?
Based on the content, sir, if in case it is Meckel's diverticulum is present, then it is a Litter's hernia, sir. If in case the appendix is present, it is the Amman hernia, sir.
Any other hernia name? Yes.
Sliding, no, sir, I'm not sure, sir.
What is sliding hernia?
So, sliding hernia, it is the posterior boundary of the sac is bound by a visceral structure. So,
Posterior wall is deficient, which is formed by the
visceral structure. So, it can either be sigmoid colon or the bladder.
Bladder, the center, sigmoid or cecum on the right side.
Okay, sir.
That is one thing. Okay.
I'm not sure about other contents, sir. If you could tell us.
Have you got to find out what is Richter's hernia, Meidel's hernia?
No, sir.
Yeah, it's given in all books. Richter's hernia is nothing but a circumference of the intestine is held up.
Okay.
Meidel's hernia is a W shape.
Okay, sir.
Intestines inside the sac.
Yes, sir.
These are some of the common hernia they may ask you. So they will ask more, not more than that. Okay. If you keep answering well, they will ask you more.
Yes, sir.
Now you ask any, you can ask me any doubt if you have. Teju, any doubt? Shivani?
So, is the treatment the same? Like, if we have to say the treatment, just the treatment, not the management, for both indirect and direct, and for strangulated, like how do we change according to our case the treatment protocol? Like how do we do it?
Treatment protocol is the same. As far as complicated is concerned, uncomplicated is concerned, it is the same.
Yes.
You are asking between male and female, or you are just asking in general?
So you explain it, sir, like.
No, it's general, it is the same.
Yes, sir.
Only thing it is easy in males, in females,
Okay,
because
sir.
there are no cord structures.
Yes, sir.
Whereas in males, it is bit not it's difficult. It is more not that easy as in females. The treatment for uncomplicated inguinal hernia is tension-free hernioplasty, whether it is direct or indirect.
Yes, sir.
Okay, when you do, but indirect, you don't open the sac. Indirect, you open the sac.
Yes, sir.
Now, when it comes for complicated, it is irreducibility, means it should be taken up as an emergency.
Yes, sir. Because
we do not know the irreducibility, if left over a period of time, it may go in for obstruction and strangulation.
Yes.
So all irreducible hernia, don't try to reduce it forcefully. You see a case in the ward in the midnight, patient comes with irreducible hernia, don't try to forcefully reduce it.
Yes, sir.
Because what happens is, there is a mass inside the sac. We do not know what happens to the mass afterwards. Okay.
Yes, sir.
So what happens? You try to reduce it. It becomes a reduction in mass. That is the thing which is called.
Yes,
So
sir.
Don't do a reduction in an irreducible hernia. You take it as an emergency. You have to open up. Okay, there, since it has come, it is coming down. The incision will be a bit longer incision. It will be an inguinoscrotal incision in an irreducible hernia. Okay. After, you have to open the sac first in an irreducible hernia. Let out the toxic fluid inside.
Yes, sir.
Then release the constriction band. There will be a constriction band which is usually near the superficial inguinal ring.
Yes, sir.
So you have to open the sac first, then see the intestines. Sorry, contents. It can be a omentum alone. It can be with the intestines. So you have to look whether it is gangrenous or non-gangrenous.
Yes, sir.
If it is gangrenous, you have to open through the abdomen and do that is going a bit long. We'll discuss it another day. Okay. You have to do a resection anastomosis. If it is non-gangrenous, you can just wait, see the viability and push it inside. If there is no much of toxic fluid and the hernia site is clean, you can put in a mesh. Okay.
Yes, sir.
If it is contaminated, you just do a herniorrhaphy.
Yes, sir.
So only thing is, in complicated cases, always take it up as an emergency.
Yes, sir.
That should be the take-home message.
So just sorry to interrupt you, but there is that one point that you said, sir, like if you push it, if you reduce an irreducible hernia, you said some terminology.
Yeah, what happens is this: there is a sac. There is a mass inside the sac. That is why what are the causes for irreducibility is there is additions between the sac, addition between the contents.
Yes, sir.
There is addition between the sac and the contents.
Yes,
Okay.
sir. Yes,
So
sir.
there will be something with the mass like thing will be formed inside the sac. So some people will try to reduce it by lifting the lower end of the bed, give some diazepam or relaxants, and try to push the mass inside. If it is an early case of irreducibility. So what happens is the mass will go inside the abdomen. This is called reduction in mass. Reduction ENMASS. Okay.
Yes, sir. Yes, sir.
So what happens is we do not know what is inside the mass.
Yes, sir.
Is it viable or non-viable? Nothing. So it will be going into the abdomen, and you are pushing the toxic fluids. These are all quite a bit. I will tell you if you want, since you asked. The toxic fluid will go inside. It may cause again severe abdominal pain, peritonitis. So that is why once you see a complicated inguinal hernia, immediately proceed with emergency surgery.
Yes, sir.
It is what we should do. Okay.